Hello, everyone, and welcome to Persist Grand Rounds. This is an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. I am Marie Terrell, Director of Product Management with Persyst, and I'm here today to introduce our speaker and topic for today's Persist Grand Rounds. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persist Ground Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their expertise and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. And next slide, please. Oh, sorry, go back one. My bad. Yeah, the opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst, and Persyst is not providing any form of compensation. Okay, and then the last slide. So this talk is being recorded and will be made available afterwards. And we will have time for Q&A after the talk. There is a Q&A button at the bottom of your screen that you can use to type your questions. And today we welcome Dr. Ayman Alboudi as our speaker for today. Dr. Alboudi is an assistant professor of clinical neurology with the epilepsy division at Wayne State University. He is a board-certified neurologist with a richly diverse medical background spanning from Syria, the UK, the United Arab Emirates, to the United States. He earned his medical degree from Tishreen University and completed his neurology residency and was chief resident at Al Musat and Al Assad University hospitals in Damascus. He holds the Syrian Board in Neurology and further distinguished himself by earning the UK Neurology Specialty Certificate and membership of the Royal College of Physicians in London. Dr. Alboudi completed his neurology residency training at Staten Island University Hospital, Lenox Hill Hospital in New York, where he served as chief resident and actively participated in the institution's medical education track. He later completed a fellowship in epilepsy at Wayne State University, Detroit Medical Center, before joining the department as faculty member on July 1st, 2025. Dr. Alboudi's research focuses on epilepsy, autoimmune disorders, neurovascular disorders, and clinical education. Today, Dr. Alboudi is speaking on the alpha-delta ratio in EEG, and the objectives are to first understand quantitative EEG principles, frequency band physiology, and the methodology for calculating the alpha-delta ratio. We will explore level 1 and 2 evidence for ADR in stroke, brain injury, subarachnoid hemorrhage, cardiac surgery, and depression. And finally, we will learn optimal thresholds, implementation strategies, and epilepsy-specific research opportunities related to ADR. And without further ado, Dr. Alboudi, thank you very much for being here.
Thank you, Mary. Hello, everyone. I'm glad to be here. I'm honored to present about the delta alpha ratio in EEG. First to start, obviously, we need to clarify that you will see delta alpha ratio and alpha delta ratio used in this presentation. And the main reason for that, different studies used different ratio. And obviously, when you use the delta alpha ratio, it will increase in the pathology problems, and when you use the alpha delta ratio, it should decrease when we have a pathology. So that's when you see those discrepancies, not to be confused. Now, without delay, we're gonna start. First, I don't have any disclosure, no financial relationship or conflicts of interest to disclose related to this presentation. Our learning objectives from this presentation: first, try to learn the quantitative EEG foundations of the alpha delta ratio, its neurophysiological mechanism, clinical applications across multiple conditions. The fundamental, we need to understand the quantitative EEG principles, frequency band physiology, as mentioned in the objectives, and we're gonna check the clinical evidence, and finally, we'll see how we apply those information in our day-to-day life as neurologists and epileptologists. First, talking about the foundations. Quantitative methodology for the EEG. Quantitative EEG converts the raw EEG signal into objective frequency domain. And we're doing that by taking the raw EEG, filtering it, dividing it into segments, removing the artifact, and then we use the fast Fourier transformation to get a final outcome with a power. When we calculate the delta power, alpha power, in addition to the others, we then can calculate the delta alpha ratio, which is the power of the delta, that frequency is 0.5 up to 4 hertz, on the alpha power, 8 hertz to 12 hertz. As I mentioned, when the study used the alpha delta ratio, they just reverse this ratio here. They used the alpha power on top and delta in the bottom. Very important thing to notice that when you look into details in the studies, you will see some of them, they use different ranges for the alpha and delta power. Sometimes you will see 0.5 up to 3.5 for the delta, 8 up to 13 hertz for the alpha, and that would be used in different places by different studies. I'm not sure, to be honest, how much this affected their results. In general, high DAR mean greater pathology. Lower DAR, preserve cortical function and better prognosis. Again, just to go through the graph, how we calculate the alpha delta ratio, we take the raw EEG, we clean it, re-reference it, apply the band passes, the notch filter, remove the artifacts. Then we take some clean epoch and we try to use the fast Fourier transformation on those clean pieces of the EEG. After calculating the band power, then we go to calculate the DAR, which is delta power on top of alpha power. Now, after we knew how to calculate the DAR, we need to know what is the normal values, because we're gonna use this to check for pathologies, right? First of all, we need to understand that there is some age-related changes in the total EEG power. And one study was done by Grieve et al. Showed that the power of the EEG decreased by age, going from almost 1 month up to 17 years old. In this population, they used mainly the central and parietal channels, and they noticed that there's a total decrease of power up to 57%. Obviously, the DAR is a result of those power ratios. So when you see decrease in the power, you'd expect the same on the DAR. And in his study, Grieve, they used the alpha delta ratio. And obviously, when you have decrease on the delta power, the alpha start to merge up, as you can see. At this is the age when you start to have proper good BDR there, reaching the 8 hertz. And we see that nice the increase on the alpha delta ratio at this age. Obviously, between 1 and 6 years old, we see accelerated myelination, cortical development, and the range change from 0.1 to 0.6, goes up the median between 0.4 to 1.3. And we see a little bit of kind of stabilization between 10 years old and 17 years old. Not that much a difference, although it is a little bit higher than before. And at that time, it reached the adult-like values, 0.5 up to 2.3, with a slower incremental increase, reflecting some ongoing pruning of the synapses. Now, you see here we mentioned reaches the adult-like values. However, unfortunately, we don't have a similar study that looked for the alpha delta ratio in the normal population at different age groups in the adult. However, we have the following. There's one study that looked at the power of the absolute spectral density for the alpha rhythm. And that's for the frequency between 8 and 13 hertz. And as you can see, the alpha power goes down with age. And I think we know in general that we expect a little bit lower, slower PDR when we see patients in advanced age. Now, when you see the alpha goes down, the general concept of that the alpha delta ratio will change makes sense. Unfortunately, that study did not look into the alpha delta ratio, and there was no clear ratios for the deltas for those patients. Uh, we did calculate the alpha delta ratio, and let's say we have clear normatives and we just said, okay, these are the normals. Now, is it reproducible? Which is very important. You don't want someone to come and measure the DAR for a patient, tells you, okay, this is a 5, and this is very bad. And then the next interpreter will read it, tell you, no, this is like 2.7. And this is for the same patient, of course. Obviously, that's not good. One study looked into different quantitative EEG measurements, and DAR was one of them, and showed that intra-record reliability was very high, up to 0.99. Inter-rater and intra-rater reproducibility was also very high at the 0.95 for both of them, as you can see here. So this is a good test that is reproducible. Different reader should have different results. And by that, we kind of established the basics of the alpha delta ratios. Now, as you notice, the majority of the applications is related to stroke, subarachnoid, and delayed cerebral ischemia. So let's look at the relationship between the EEG and the cerebral blood flow. In fact, not a lot of studies that looked specifically into normal cerebral blood flow and the relationship to the ADR or the DAR. One study that was done about like 50 years ago. That study looked on the mean EEG frequencies and its relationship with the cerebral oxygen uptake. They found a very good correlation, and it was 0.78. And actually, they found that the correlation for the gray matter flow was stronger than the white matter flow. And that correlation holds across chronic stable EEG patterns. And obviously, what matters for us and EEG readers is the cortex as the major source of our EEG. Now, let's start talking about some pathologies here. The first, we're going to talk about the delta alpha ratio in ischemic stroke diagnosis. In this pathology, we're going to split it into different stages. The first one is the hyperacute phase, 0.0 hour to 4.5 hours. This used to be the window for thrombolytic therapy. And as I heard just today, one of my colleagues in the stroke service was telling me the new guideline just came out for an extended window. So this will probably need to be modified, and we need a new study for that hyperacute phase. Anyway, on this hyperacute phase, a study was done looking into the EEG changes and looking into the DAR in that critical time window. What they did, they looked at the delta ratio, the delta power, the alpha power, and then the DAR. And they found there was a correlation between the delta, which increased, the alpha is increased, as you can expect, but the DAR was the strongest predictor. With obviously, you can see here a correlation 0.81 that was significant, 0.001. Now, the DAR obviously outperformed both alpha and delta when they were taken in isolation. It is important to notice that in this study, they looked at the global DAR and the global alpha and global delta. It's not about you will see these changes on the side of the stroke or not. So it is diffuse bilateral alteration that we see it in the hyperacute phase. Probably it reflects some disruption of interhemispheric connectivity rather than the focal changes related to the stroke itself. If we will look into the graph, you can see how the alpha negatively correlate with the NIH score and the hypoperfused volume and the core volume. It's important that the correlation is very high with the inertia score. That tells you that if you will put EEG on a patient head, now we can tell you at least something very close to what you'll expect clinically on him after the patient is having a stroke. That's a very important factor. In addition, the hypo perfused and the core were also correlating. Now, that is important when we talk about the severity, because that will apply later on when you talk about the patient rehabilitation and what type of care the patient and level of care the patient need to receive. Now, moving to the acute phase, now we're talking about 8 to 24 hours window. There was a study looked at the EEG during this window, and actually the numbers were magnificent. Now I know some of you will say, whoa, 100%. This is the magic test, right? That's what we want. Every one of us, we want that. We need to take this with a grain of salt, and I will tell you why. First of all, this study looked at EEGs and they tried to find the DAR threshold. And when they looked, they found the 3.7 was the magic point. Everything above 3.7 DAR was a stroke patient, and everything below the 3.7 point was not a stroke patient. So they 100% distinguish between radiologically confirmed acute ischemic stroke from age-matched healthy control. Why do we need to take this in a grain of salt? We'll talk about it in a minute. The DAR here was 6.64 for the stroke patient, the acute stroke patients, and the normal, it was about 1.34. Control representing five-fold almost increase on that DAR. What about reperfusion? Before moving to reperfusion, I will tell you, when they looked at the DAR here, they looked also like the previous study on the global DAR. It's not related to the side of the stroke. However, it is important to mention that this study used only 18 ischemic stroke patients and compared with the 28 healthy control. All of those patients were in the anterior circulation. The majority of them also were MCA territory, with every single one of them cortical involvement, except one of them was subcortical. So as you can see, the patient included in this study has some specific characteristic, and most likely that's why we have those magical numbers here. Nevertheless, the numbers are significant. Now, in part of these 18 patients they used in this study, some of them they received reperfusion, like thrombolytic treatment or thrombectomy. And actually, two of them, they had the number of DAR above the 3.7. That dropped significantly below this point when the reperfusion happened. One of their patients had reperfusion and their DAR did not drop and the patient did not improve completely. And that's why they came with this conclusion about the benefit of using the DAR as monitoring for those patients receiving the tenecteplase, the thrombolytic therapy, or thrombectomy. Phase specific, it's important to remember, and that also add to the limitation of the study, that they used EEG less than 24 hours. If you are looking, and as we will see in a later study, if you look at the EEG after that in the subacute, especially more than 48 hours, this number does not really apply that much. And you can expect the number will go down, and you need to find something lower to differentiate between stroke patient and normal population. We'll come to that in a minute. Now, this graph shows those parameters they were looking at into this study, and you see the one for accuracy, sensitivity, and specificity for the DAR. The delta theta alpha beta ratio is another ratio. Use the slow waves compared to the faster waves, and it gives a very good sensitivity and accuracy. Specificity is a little bit low, and probably the explanation because this one will have a little bit more artifact related because of including those faster activities and the theta. The relative Q slowing, relative alpha and delta shows some correlation, but they were not as good as the DAR. Now, Moving to the next stage of the stroke, I'm talking about the subacute stage. Those patients, 48 hours up to days. This is a study done by Finnegan et al. They looked at EEG for those patients, 49 hours plus minus 3 hours, and they tried to see if the DAR is related or can be correlated to the inertia score at 30 days. So now we start to talk about prognosis here, not only the diagnosis. And they found actually the DAR very strongly, positively correlating with the inertia score at 30 days. I need to bring your attention, although you see the correlation here is 0.91, it is important to remember that in this study, they used a 62 channel system. I'm not sure what was the rationale behind the 62 channel. Probably they just tried to have better resolution of the EEGs on those patients. But using that 62 channel, they had a correlation of 91. However, they did check that correlation on the traditional 19 channel, and they found actually also a good correlation of 0.82. So, sorry, this is for the alpha power. And I believe I mentioned 0.81 when they corrected this for the 19 channel maintaining compared to the 62. Obviously, the 62 is a little bit better, but nevertheless, this one is a good correlation. It was statistically significant. The alpha power also showed some correlation that was negative correlation with the 30-day inertia score. And these two were the main or the only statistically significant measure for quantitative EEG as a correlation with 30-day inertia score. In this population, now we can see the mean DAR for those subacute patients, 5.63, which was less than the one before, compared to 1.58 in healthy controls. The increase was 3.6-fold, which is significantly less than when we saw it in the acute phase. We talked about like 6 times difference, right? This study also has some limitation by including only 13 patients. Obviously, this is not enough to build your criteria on it. You'll need bigger studies, multi-center studies to have a better idea how to correlate and if that correlation will stand after that. At 48 hours, the DAR demonstrate exceptional predictive value for the 30-day clinical outcomes. We see that the DAR range from 1.38 with an inertia score of 1. You remember when we talked about that subacute state on the acute stage when we found the 3.7. Here, 1.38 was still a stroke patient. The inertia score was low, 1. On the previous study, none of the stroke patients had a DAR less than 3.7. So the timing of your EEG plays a role choosing your reference or the threshold of the DAR you're talking about. And the DAR when was 14.15 and a score 133 and the patient deceased, demonstrating wide dynamic range for this one. Now, another study tried to look at portable EEG, a small portable machine that can easily be applied, and it needs 5 minutes to set. And what you need, only 3 minutes of recording with the eyes closed and clean EEG. And they found that the DAR significantly increased with the stroke severity. So the main purpose of this study was to look into the severity of the stroke patients. And actually, there was 76% accuracy distinguishing between a severe stroke from minor stroke or controls. Now, to tell you what does it mean, those patients with acute stroke handled by the EMS people, they've been assessed by the Los Angeles Motor Scale to decide if those patients do they have a large vessel occlusion or not likely. The accuracy of the LA that is usually used is 0.72, like 72%. This study showed 76% accuracy of detecting severe stroke patients. And that obviously can help the paramedics in triaging decision between specialized comprehensive centers versus just standard hospitals. Optimizing patient routing instead of sending a patient with full MCA occlusion to a standard hospital. Using this method, you are more accurately to send this to a comprehensive stroke center. Now, that's very nice and lovely, right? However, pay more attention to this here. This study was not really done in the pre-hospital environment, unfortunately. It was done 3.71 days as mean from it. Now, the range was 0 to 16 days. So this number might be true, but obviously need to be confirmed in a pre-hospital environment. This is number one. Number two, you look at this term here, classification tree. So this one study did not choose one single parameter to look at to detect the severity of the stroke. They used a classification tree, and that tree used the following parameters. The first one was the pairwise derived brain symmetry index, the DAR, the delta theta alpha beta ratio, and head movement variability. So they used four parameters to reach this accuracy. I mean, this can easily be calculated using the right software, so shouldn't be something to as a take on this study, because nowadays with the AI and everything, you can calculate whatever you want in seconds. But I think the major problem with this one, these results were done at way after the pre-hospital stage and need to be reproduced in the pre-hospital environment if we really want to use it for that purpose. There was another study where they looked at a very hyperdense EEG. They looked on 256 channels. And this study, interestingly, they looked in the hyperacute phase. Now, the EEG was done within 6.6 hours from the emergency department arrival, from the stroke onset, and it was done within 1.9 hours from the arrival to the emergency to the EEG. Now, when you use the 256 lead EEG, the ADR, they looked at the alpha delta ratio on this one, which is different from all the previous studies. They found a negative correlation, minus 0.7, when we measured the ADR whole brain, as we compared it to the contralegional ADR. Now, bear in mind, all the studies we talked about, they looked at the DAR, the delta alpha ratio, on the whole brain. This is the first one we were talking about. Start looking at the side or the other side, like contralateral or ipsilateral, for the lesion. This study found that the alpha delta ratio has negative correlation with a stroke and excellent diagnostic performance with the contralegional side. The whole brain ADR was correlated, minus 0.7, but the contralesion was higher. These findings were still there when we looked at the 20 lead clinical equivalent, the 1020 montage, the usual one, and also showed that there is whole brain correlation, minus 0.75. The contralesional went a little bit down to minus 0.68 and maintained showing improved significance and good for varying clinical feasibility. Now, the study showed 256 and the 20 lead did not decrease the diagnostic utility. Standard clinical EEG equipment was sufficient for large acute ischemic stroke detection. So this study was able to show that significant difference between large acute stroke and small stroke to a normal population, supporting the rapid implementation of ED in the pre-hospital settings. This one add to the evidence that we might be able to use the EEG in the pre-hospital environment, especially as we said, this was done within 6.6 hours from the stroke onset. The problem that we really didn't have enough patients to have a very strong recommendation from the study. The total number of subjects was 24 subjects, 14 with acute stroke. Only 5 of them were of a large stroke, large acute ischemic stroke, compared with 10 patients without a stroke. That's good correlation, good results, but obviously still need to be replicated in a multi-center, large population study. Now let's go and review it a little bit. Temporal evolution of the DAR, the hyperacute 0 to 4.5 hours. The median EEG was 178 minutes. And DAR strongest predictor for the NIH score with a clinical correlation that we can use it when you have a patient with aphasia, patient is confused, not cooperative, a patient is in coma. Direct correlation with the hypoperfused volume and the core. Critical window for reperfusion therapy with bilateral changes. In the acute phase, 8 to 24 hours. And the threshold for the DAR was 3.7. That was the magical number of the 100% sensitivity and specificity. The subacute at the 48 hours up to 7 days when we start to look for prognosis here. And we noticed that the DAR has a very good correlation with a 30-day NIH score. And as we mentioned, the portable system, although it was done with a mean 3.71 days, showed promising results that could help with the pre-hospital routing for those patients with big strokes. Now, let's talk a little bit more about the rehabilitation. Delta alpha ratio and ischemic stroke rehabilitation and the prognosis. There was a study done in rehabilitation centers. They checked the EEG on all those patients on the admission to the rehabilitation facility. So those patients, they had their acute stroke, been admitted in the hospital, in the ICU, on the floor, or whatever, and then those patients moved to a rehabilitation facility. So EEG was done and the DAR was calculated for those patients on admission, and it showed higher correlation with potential recovery. So the higher the DAR, the worse the recovery. As you can see, it's negative correlation, 0.65 minus. The DAR, median DAR was 1.47 for stroke patients. And again, this to confirm, when you go further from the acute stroke, the number or the threshold for the DAR go down. And good recovery was with 0.64. So the poor recovery was seen with a 1.47. Good recovery was seen with a DAR 0.64. Probably the mechanism here just reflecting the increase of the delta elevation with reduction of the alpha that shows some differentiation, decreased attention dysfunction, and the recovery of the patient that will take all these together. The application for that, how that would help. When you do that EEG and you found that high DAR value, you know that this patient is likely to have poor recovery. Maybe you may put those patients in an intensive rehabilitation, and that hopefully will help them to get a better prognosis. So that probably could help those patients. The other factor they looked at in correlation with the DAR was cognition after the stroke. We know that cognition is a major factor that will affect quality of life of our patients. And in this study by Schleier, they looked at frontal leads. They used F3, F7, F4, F8, and they looked at the DAR on these electrodes only. So it's not a global DAR, only for the frontal leads. And they compared it with the functional independence measure and functional assessment measure, the FIM-FAM, at 3 months. And they found that when you look at the frontal DAR and you compare it with the global alpha, posterior DAR, or global delta, it was very good correlation of the frontal DAR and showed assessment at 72 hours post the stroke. The correlation was good with the cognition of the patient at 3 months. The superior, the higher the DAR, the lower the recovery of the cognition. They did not come out with a threshold to tell you which one would give you a bit what result of cognition. Unfortunately, the size of the study was not big enough to come with these numbers. Now we'll leave the acute stroke behind us. We'll move to the subarachnoid, another big problem that we see in our neuro ICU. Subarachnoid hemorrhage with the delayed cerebral ischemia, looking for the DAR or the alpha delta ratio for those patients. First of all, the delayed cerebral ischemia in subarachnoid happens in almost or about like 30% of those patients. The general range of days is 4 to 14 days post ischemic stroke. And the delayed cerebral injury, it happened with those patients and it caused permanent injuries for those patients. Now, looking at the numbers from each study, and that's what we'll do first, then we will go to a meta-analysis for all these studies. This study from 2004 was the landmark for studies for those patients with a subarachnoid. They looked at 34 poor grade subarachnoid patients with a HES 4 to 5 with a continuous EEG from post-op day 2 up to 14 days after the subarachnoid. They found that the ADR performance showed decrease of 24% in the DCI patients versus 3% increase in the non-DCI group. The area under the curve was 0.83. Not bad, right? They found there's the criteria they used to diagnose those patients, either one of two. You will find 6 consecutive recordings with more than 10% ADR decrease that will give you 100% sensitivity with a 76% specificity. Although you may give some false alarm here, but this will allow you not to miss any of those DCIs. If you will use a single measurement of your DAR on the EEG, you will need more than 50% decrease on that ADR. Even when you're going up to a 50% decrease on one measurement, the sensitivity drop down about 90%. Specificity goes up a little bit, up to 84%. So this is important for you guys to pay attention because this is one of the major problems when we look at the DAR or the ADR in DCI in subarachnoid patients. These parameters are different. Unfortunately, there's no consensus on them. So moving to the next studies. So in this one, as a reminder, 6 consecutive recordings with a decrease more than 10% of the ADR give you a good sensitivity, acceptable specificity, or one single measurement showed more than 50% decrease on the ADR. Rosenthal in 2018, with his prospective validation, they looked at 103 high-grade subarachnoid. And they looked at the continuous EEGs for about like 7.7 days. They had pre-specified EEG alarms. So they had a criteria. If that criteria is met, you will call the alarm and you will suspect the DCI, take your patient for investigations or intervention possibly. Those alarms will go when you have a decreasing ADR that is approximately 10% below the baseline, persisting at least 6 consecutive hours. Kind of similar to the previous studies, but the previous studies mentioned 6 consecutive measurement, and the measurement were done every 15 minutes. This one was 6 consecutive measurements every the measurement are done every 1 hour up to 6 hours, or more than 50% decrease from baseline that is continuous for 1 hour. The previous study was showing the 50%, but it was one single measurement. So this is the first difference we see on the criteria. The other alarm they used, decreasing the relative alpha variability, focal slowing or drop out of the fast activity, increasing epileptiform abnormalities. So it was not only the alpha delta ratio here used. And when they used the EEG alarms, they had 96.2% of those patients we were able to detect, compared to 19.6 of false positivity. So sensitivity was 96%, specificity was about 80%. The ADR alone significantly showed sensitivity of 32% only. So specificity was a little bit higher, 90%, but that was a very important setback. Sensitivity of 32%, you will miss a lot of your patient if you will do the ADR alone here. The clinical lead time for this patient, when they were able to recognize those patients of the possible DCI, 1.9 days. That's a lot of time to intervene of those patients. More than 82%, they were captured more than 12 hours before the problem happened. Obviously, this is critical when you are planning to intervention, right? Now, Rots in 2016, he had another study looking at the same target here. And when they did it, they checked the quantitative EEG and they detected it median 7 hours before clinical DCI. So this one was useful to detect those patients before you see any clinical finding on those patients 7 hours before. Diagnosis was 44 hours before the CT scan evidence. When we combine the measures, the ADR plus the alpha variability, we achieved highest diagnostic. The area under the curve was 91.7. Not bad. That's a very good accuracy, right? But notice here, it's not the ADR alone. It's the ADR plus the alpha variability. So when you have decrease on the ADR and lose of the alpha variability, that's when you use the 91.7%. And rods, they looked at a threshold. Let's see what threshold will give us the best. And they found a new one compared to the previous guys, 10%, 50%. They looked like 38% decrease in either the alpha delta ratio or the alpha variability, provided 100% sensitivity and 83.3% specificity to detect the DCI. This is another new number here. And we just talked about 3 studies. We see 3 different parameters. There's someone who came up and say, okay, let's take all these studies, check the alpha delta ratios in DCI and subarachnoid patients, and see what can we come up. After reviewing a lot of studies, they found these 5 studies were eligible to be analyzed in terms of they were not biased, they have enough data that they can do the meta-analysis on it, and they came up with this table here. 2 retrospective studies and 3 prospective studies. As you can see, the number of patients in these studies, the highest was 103, but all of them like less than 100, right? The ADR threshold, 10% decrease for 6 hours. 70% decrease for 2 hours from Germany, 38% decrease from Netherlands, 10% decrease for 2 measurements from the 2018 study from US, 10% for 6 hours or 50% for 1 hour from Rosenthal. Like 5 different studies, 5 parameters. Anyway, let's see what this meta-analysis looked at. They pulled the data here and they looked at it and they found, after pulling all the data, we have good number, like the accuracy was 0.84, the area under the curve. Not bad, demonstrate a good discriminative ability. The study design, is it retrospective or prospective, influenced the specificity. And the specificity was higher when we had those prospective studies versus what was 92%. Retrospective studies showed lower specificity, down to 54%. Now, key findings from this meta-analysis. There was high sensitivity here. The pooled sensitivity was 83%, indicates the alpha delta ratio reliably detects the most DCI cases. Now, specificity was good, as the pooled data was 74%, shows moderate ability to exclude non-DCI patients. You will still have good number of false positive. Area under the curve was good and very good actually, 0.84. That's very overall good predictive performance for a test you do to check. We will see in a minute some comparison with other tests. And they checked those studies for any publication bias, and there was none. Now, comparing uh, the alpha delta ratio from this pooled studies with the sensitivity and the specificity of other tests, including the TCD and the CT perfusion. Interestingly, you will see that is really very comparable. 84, 74 for the ADR for sensitivity specificity. It's better than TCD here for specificity, better than CT perfusion for sensitivity. And you can see it's really comparable. And that's something you can monitor the brain continuously. You will see functionality. It's not a one-time test like when you do the CT perfusion, and you can just leave it there for days monitoring those patients. In addition, you will be able to have some time before the clinical deterioration happen, as we noticed, up to 1.9 days before the clinical deterioration. That obviously very important when you are planning to intervene. Challenges in a clinical implementation of these data. This is the problem here. These are a great number for sure, but the problem is the thresholds used across those studies were different, from 10% up to 70%. So what to use? Unfortunately, at this time, we don't have good evidence for an important, a good study with a good number of patients to give us these numbers. Now, we don't also have standardization for the clinical protocols. This need to be designed and stated before we start using this widely. Automation limitations. In 2016, a study working showed that automated ADR algorithms performed poorly, near chance, without accounting for sedation and sleep stimulation. Now, we're not gonna sit and calculate the ADR manually for those patients. However, just keep it all automated. It was not that good. Now, keep in mind that was like in 2016. We know that every day we have something new and we have improvement. In 2016, there weren't that much of AI applications in the market that can help you doing such a great job as now. Like this is 10 years ago. There's a huge advance. So this one, maybe at some point we'll be able to overcome and get rid of it. The artifact management requires skilled interpretation for that the EEG advancement and the artifact rejection to prevent false alarms. Resource requirement. Continuous EEG monitoring obviously requires sources. You need the machine, you need the technician to hook a patient on that. And when you are looking for a DCI monitoring, obviously you need someone sitting in front on that screen all the time. Most of the studies, they were looking at the EEG twice a day. That's probably good enough, take into account if you have good alarm signs that will give you enough time before the clinical deterioration. And if we are talking about the new AI application on those studies, probably you will not need as much as in front of the screen person to keep monitoring these values. Clinical implication and future direction from here. What we need to do here. First of all, the ADR monitoring mostly for the high grade subarachnoid. So when you have hand and Hess 4 and 5, because the majority of those studies, they chose their patient to have high grade. So you have a patient with a low grade subarachnoid, we don't know really if the ADR is useful at all for those patients. The early EEG alarms may enable preemptive therapy escalation before irreversible ischemic damage occurs. Those patients, you can capture them before even they start to have the clinical problems, the presentation of the DCI. We need to refine the algorithm used to come with these values and integrate a clinical covariant like sedation scores and stimulation timing. It's important to remember that in the ICU environment, there's a lot of stimulation, lines, machines, noises. Those all affect your EEG. And that's why we were talking about when we were calculating the ADR, we clean the EEG, then we choose the cleanest portion of that EEG to calculate the ADR, as we said before. And last but not least, we need standardization. We need a consistent guideline required to have the threshold of the ADR to define when we think that this is the best value to check for the ADR to respond. And we may need more parameters to join the ADR to have a better response protocol for those patients. Now, enough from the stroke and the DCI, moving to some other clinical application here. First, those patients with cardiac surgeries, when we do neuromonitoring for them. And this one is just simply looking on the direct effect of the cerebral blood flow on the ADR. One study was looking on those infants. They did cardiopulmonary bypass for aortic arc construction, and they looked at the DAR during those procedures. The ADR, actually not the DAR, sorry, it is the ADR they looked at, and they found that there's difference more than 0.1 that preceded neurological injuries. Some of those patients who did that surgical procedure, they had some complications that include a stroke or a seizure, and they noticed that those patients, they had significant difference with change of the ADR by 0.1. And it happened 50% on those patients, while it happened only in 7.8% with patients without complications. The correlation with the perfusion was really strong and showed 0.73. And in this study, they used the ADR and they used the suppression ratio. That's something important to remember. And the dynamics here, we look at the stages where the ADR was different in different stages of the surgery. So there's a 3 stages when you do the cardiopulmonary bypass. Usually there's a cooling, there's antegrade, cerebral perfusion, then there's a rewarming phase. The ADR was the highest during the antegrade cerebral perfusion, and it was the lowest during the rewarming phase correlation. That was not that much important per se, but it's important to remember when you look at those differences. So it is expected for your ADR to drop when you move from the ACP to the rewarming phase, and it's expected to increase when you move from the cooling to the ACP phase. So when you have more than 0.1 a change inside the phase, that will tell you that your patient's more likely to have neurological injury. The strong direct correlation between the ADR and cerebral oximetry was also found by 0.73. Now, moving away from the blood flow, let's talk about depression here. That was a little bit unexpected when you look at the ADR. This is a new application. They looked at a population age more than 50 years old, and they looked at the delta alpha ratio during sleep, both in the non-REM sleep and the REM stages. And they found strongly correlated with the depression severity in older patients. And they found that the non-REM DAR and the REM DAR both independently associated with a positive and negative correlation, as we will see here. So for the diagnostic accuracy for the severe depression, the non-REM DAR area under the curve was almost 70%. Sensitivity was 65%. Not great, but not bad. However, specificity was very good, 81%. The optimal cutoff for that was 14.65. You see, this is completely different reference value. However, keep in mind, we're talking here about DAR done during sleep, and this is non-REM sleep, so it's a slow wave sleep, and you expect to see a high DAR here. The risk association, each unit increase in the non-REM DAR increases severe depression probability by 41%. And they use the model here, so it's not a pure DAR situation or information used to get that diagnosis or that guessing. As we will see, implementing multiple markers mean is usually required to get the better results. And as we say here, the increase, the change or the increase on the non-REM DAR increases the severe depression probability by 41%. And in fact, the increase on the REM DAR was protective. For some reason, I did not put a percentage, but it was protective according to this study. Now, depression severity by the DAR, depending on those, they had like 88 participants on this study, 30 normal cohort, 22 mild to moderate depression, and 36 severe. DAR values were higher in the severe depression compared the moderate and the mild depression patients. So this is not to diagnose depression, rather to tell about the severe depression. Positive correlation with Hamilton Depression Rating Scale, and it reflects the cortical inhibition and arousal regulation of normotensin in depression. The association shows some deficit in attention, in working memory, emotional regulation. So the sleep EEG ADR may enable objective depression severity assessment for those patients. Now, by the end of our presentation, we need obviously to talk about the limitations and the study challenges. The known limitations. Current literature with the ADR contains multiple methodological problems. All of those studies were modest sample size. Almost none of them, except maybe one or two, you will see a size more than 100. Population were heterogeneous, as you will see from the last studies. Some of them mild, moderate, severe, either for depression or for the stroke, the DCI. So compared to normal population, the age was not enough studied to compare variable ATR definitions, and thresholds was invented, or like they came up with different definitions and thresholds to decide different diagnoses. The lack of standardized protocols obviously is a problem here, and limited long-term follow-up to check how good those are, especially when we talk about the prognosis for the cognition and rehabilitation. There's a lot of confounders that interfere with the ADR calculation here. Some of them pharmacological, the propofol, benzo, especially when you talk about ICU patients and environment, other sedatives. Temperature, when you do the hypothermia protocol, dramatically increase the suppression ratio and alters the ADR. In this case, when you talk about the ADR, it will decrease the ADR, while the DAR will go up. Demographically, age, baseline cognitive status, other comorbidities may affect the baseline ADR and limit direct comparison for those with pathological problems. Technical challenges related to the artifact. We have the muscle artifact, we have the eye movement, and this is in a specific is important because some studies were using the frontal LITs. So it's important to know that you need to be very careful when you choose your epoch to calculate the ADR. Muscle artifact obviously will add to the fast activity, and you see them in the frontal regions, and they may affect when you calculate your ADR parameters. Environmental, including electrical noise, other monitors, and the impedance, all will affect your calculation for the ADR. And what about research recommendations here, standardization? Obviously, the future direction, standardization priorities. We need protocol. We need to develop protocols for those things. We need the threshold definition to tell what is the appropriate values for specific age groups, specific pathologies. We need documentation, published guidelines in major neurology and neuromonitoring societies, create standardized reporting templates. And last but not least, you need to integrate multimodal neuromonitoring. It's not only the IDR will give it all. You will need to use it with the transcranial Doppler, with the intracranial pressure monitoring in case in the ICU, with the structural neuroimaging like CT perfusion, or even DW or the MRI. And by that, we come to an end of our presentation here. Hopefully, I made this topic a little bit easier for you guys. I know there's a lot of differences here and changed things compared to the thresholds and values, but hopefully you enjoyed it.
Thank you, Dr. Alboudi. That was a very interesting talk. I actually haven't heard of DAR before, but it makes sense given that we're trying to measure something that's global. We have a question in the Q&A, and for those of you that are still on, please feel free to write your questions. The first question is, for subacute stroke DAR prognostic value, is there anything in the literature that looks at the correlation between DAR and 90-day MRS?
In the subacute one,
Yes, subacute stroke.
as far as I looked into the literature, to be honest, I did not do a full literature review, but up to the tens of those studies I looked at, the only studies that looked for the 90 days were really in the subacute, nothing later than the 48 to 72 hours. And probably the one from the rehabilitation center was the most one that looked for the 3 months rehab outcome for the Irish score. Not pretty much the MRS as far as I remember. The one from the subacute mainly looked for the 30 days in Irish score. And that's why we mentioned that we really need a longer follow-up. And you're right, that's not good enough. We know that this still may change.
Thank you. So because we have a mixed audience here, and it took me a minute to realize as well the why we use DAR in certain situations and ADR in others. And would you say that we use DAR with stroke monitoring because we're assessing for an event that has already happened, and so it's trying to get a sense of whether or not something happened. So you don't necessarily need sensitivity in terms of change over time. But with monitoring for vasospasm and subacute hemorrhage, you do want sensitivity over time, early warning, and things like that, which is why the ADR is better for that. Can you talk a little bit about why we use one in one situation and the other
Sure,
in?
sure. Very good question. Very good question. As I mentioned in the beginning of the lecture, those ADR and DAR, they are the same. Just you reverse, you put delta up and alpha down when you calculate, and you reverse it when you do the other one. And instead of having, let's say, ADR of 4 or DAR of 4, you will have ADR of 0.25. So in terms of correlation with any pathology, either one of them you calculate, you should have the same correlation. There shouldn't be a difference. Otherwise, there's a problem. I don't know why some studies they looked into the ADR and others looked at the DAR. Probably that's what was used in the institute because almost every single one of those studies were a single center study. So there weren't a lot of centers inside those studies. So probably it was center driven protocol to use one compared to the other. Now, talking about the sensitivity, when you talk about the acute stroke, that it is not important. And when you talk about the DCI, it is important. That could be right. However, one exception, and a very important exception, would be when we look at the pre-hospital scenario, when you use that nice tool of the portable EEG, try to differentiate those patients with severe stroke. You need to be really sensitive with this to not miss any of those severe stroke and send them to centers with a comprehensive stroke centers where they can do thrombectomy for those patients. Obviously, sensitivity in that situation matter. Now, when you have the patient already in the hospital, does sensitivity matter? I think it does when it is good enough to differentiate stroke from non-stroke. I don't think we are there yet, but if we are at the point that we can differentiate stroke from non-stroke, then you can decide if you're going to give thrombolytic therapy or not. Because, we see many of those patients come to us and they have neurological symptoms that is improving. And some people, they choose to give the thrombolytic therapy. Some people they choose not to give, regardless of the guidelines. I'm not discussing what the guidelines recommend here, but it is depending on your discussion with the patient, with the family, with the side effect, the patient comorbidities. However, when you use EEG as additional tool to tell you, okay, it seems although CT scan did not show anything, we know it is not going to show for a few more hours. This EEG is telling me, though you are likely having a stroke here. So I think giving a thrombolytic therapy is a good idea. That's how I would use the sensitivity here. I hope I answered your question.
Yeah, that makes a lot of sense. Thank you. We've got more questions coming in. So the next one is, has DAR shown any use for Alzheimer's disease or neurodegenerative conditions?
Sorry, come again?
Has DAR shown any use for Alzheimer's disease or neurodegenerative conditions?
I'm not aware of Alzheimer's specifically. I'm sure, to be honest, I did not look into the Alzheimer per se and degenerative. I did not stumble with any study looking into that specifically. Now,
Yeah,
it's important to refer that they looked at cognition, but it was in stroke patients. Would that
right.
be the case? I'm not sure because when you look at Alzheimer, this is something chronic. I don't know how you will be able to see a change because the majority of those studies they were looking at a change in the DAR or the ADR.
Yeah,
In Alzheimer's disease, something happening over a long time is I don't see the value of looking into change of the ADR. Maybe some other new parameters will come or some threshold will tell you, okay, this is the normal ADR for general population. And if you go above, now we start to see cognitive problem and we need to look into neurodegenerative diseases. However, as I mentioned, we still don't have normatives for normal population for the ADR or DAR.
right. I think another consideration in terms of thinking about Alzheimer's is that the mechanism of the disease is different. I don't know that it's about a disease of perfusion. It's more one of neuronal dysfunction, and I don't know that. I mean, maybe ADR would be useful in that situation. Obviously, we'd have to look for studies on it, but it's different. Um, okay, next question. So, given that many studies used global DAR rather than per channel, does it seem feasible for a limited channel montage, such as a hat band device, to allow for less resource-intensive deployment? Did the SAH papers focus more on per channel changes? Standardization of methods will help in the future. Thank you for the discussion.
Very good question. Very good question. And I noticed that variation actually in the studies. And when I was looking into those studies for the acute stroke or the ischemic stroke, I think one of them looked for the regional changes, and they found the contralesional is more significant than the global. Um, Probably you're right, but I don't think that we have enough evidence to say that this is absolutely better, that the global is better than the regional. Keep in mind that when that study for the portable EEG, when they used the frontal lids, that showed significant correlation. So that tells me at least we have correlation for the frontal leads. They compared it with the central leads, and they found that the frontal leads were better than the central leads. And again, the leads used were F3 and F7. So if you look at it, we're not talking about the FB1 and FB2 on the front of the head. This is F3, a little bit close up to the center of the head, and F7 on the side. So probably that is a good coverage of the MCA territory here. I know that the C3 goes more to the center, but I think the F3 and F7 give a good coverage for the MCA territory.
Great. Thank you for that explanation. So next question. Thank you for this great presentation. For high grade ASAH, for how many days is it feasible to monitor the ADR?
For the after the subarachnoid hemorrhage, I suppose.
Yeah. She wrote ASAH, so maybe that's acute.
The aneurysmal subarachnoid. Yes. Sorry,
Yeah,
I don't see the comments on my screen for some reason.
no problem.
Yeah, for the studies were done. They were looking at the EEG up to 14 days. Some of them they just kept their EEG up to 14 days from day number 2 until day number 14 after the surgical correction. They did not continue up to the 21 days that what we usually use in our window for the treatment. But yeah, they kept it up to 14, day number 14.
Okay. And the clarification there was that the A stands for aneurysmal,
Yeah,
SAH.
aneurysmal
Yeah.
subarachnoid.
Okay.
Yeah, thank you.
Okay. All right. Next question. In theory, then, would serial EEGs over time detect normal pressure hydrocephalus before it causes changes on imaging?
Normal pressure hydrocephalus. I'm not sure about that. This is a very good question, but that worth studying. We would be lovely if we have someone look at it. Uh, if you will find the perfect normal DAR or ADR for a general population, then you start to compare your patient on those. You start to look for the hydrocephalus that could be uh, valid screen for those. But I'm not sure how that would be implemented clinically because I'm not aware about any clinical or something that you do to screen for the normal pressure hydrocephalus. It's a rare disease. I mean, we see it as a neurologist. We see it. We see many patients of those, but in general population, it's a rare disease. So you do not expect to do serial EEG on everyone for couple years and hope to capture those NPH patients. Unless I misunderstood the question, I'm sorry. I'm not sure we're talking about the same problem. And also the other problem would be for how long you will keep doing those repeated EEGs because there's a wide range of years that NPH may happen. So I'm not sure if I misunderstood your question. Forgive me for that, if that's the case.
Okay, thank you. Um, the next question is, given GRDA, frontal dominant delta, appears in ventricular stressed brains. Was that a question, Jessica, or was that just a follow-up to your first question? I think that must have been an addition to the to her first question. Oh, hang on. Oh, okay. So she was just expanding on the question. Okay, got it. All right. Thanks,
Yeah, I
Jessica.
mean, again, I'm not sure about the normal pressure hydrocephalus, but if you're talking about hydrocephalus per se, not the normal pressure hydrocephalus, hydrocephalus when we have, for example, a patient interventricular bleed or a lesion or a subarachnoid or meningitis, encephalitis that may cause obstruction of the flow and causing increase the pressure, causing hydrocephalus. That might be a good idea. I don't think we have studies for that, but that's very important and interesting thing to look into.
Yeah. Yeah, that would be interesting. Okay. I think we've covered it. Dr. Alboudi, thank you so much for your time. This was a really wonderful talk and really appreciate you coming and doing this.
Absolutely. Nice
All
to be
right.
here. Thank you for
Thanks,
listening.
everybody. Thank you so much.
Have a good
Bye-bye.
one.
You too.